الرحمن الرحيم. Our agenda includes an introduction, the magnitude of the problem of HCV in Egypt, the national control strategy, barriers against the establishment of this strategy and the achievements done, and the future perspective. We know that Herodotus says that Egypt is a gift of the Nile, but the Nile at the same time was the reason of the endemicity of schistosomiasis in the past years. In 1980, an estimated 10% of the 200 million persons infected with schistosomiasis were Egyptian. Starting from the 60s, a campaign for eradication of schistosomiasis was done depending on health education, annual examination treatment of children, snail control and mass treatment. But of course the price was extremely expensive, which is the spread of HCV in Egypt. Beginning in 1960s and until 1980s, the Egyptian Ministry of Health conducted a large campaign using the standard treatment at that time. It was tartar emetic injection as a community-wide therapy. More than 2 million injections were given annually to an average of 250,000 patients. Approximately 36 million injections were administered during this period using poorly sterilized glass syringes. This results in intensive transmission was establishing a reservoir of chronic HCV infection responsible for the present high prevalence. This is the largest known iatrogenic transmission of blood-borne infection in the history of mankind. 30% of HCV antibody positive Egyptian patients have a history of receiving injections for treatment of schistosomiasis. The global prevalence of hepatitis C, 4 years ago, Egypt came on the top. The prevalence was more than 10%, the same as Venezuela and Mongolia. Regarding the viremia, the total viremic HCV infections all over the world, the countries responsible for 80% of this global infection. Egypt came number 4 after China, Pakistan, and Nigeria. Before 2006, Egypt didn't have a comprehensive national program for control of viral hepatitis. There was no nationwide survey for prevalence, no national guidelines for treatment, no government-sponsored treatment program, and a limited infection control program. The major challenges were a high cost of antiviral treatment in a resource-limited country, the growing number of persons living with chronic HCV infection, continuous spread of the infection within the community, lack of specialized infrastructure, and absence of public awareness. In 2006, the Ministry of Health announced the launch of the National Committee for Control of Viral Hepatitis that starts to develop by April 2007 a national control strategy for viral hepatitis. This, of course, with the help of some other organizations like the WHO, the United Nations, CDC, Pasteur Institute, etc. The objectives of this strategy were a national survey, prevention program with treatment program, and clinical research. The principles were standardization, simplification, integration, and decentralization. This represents the centers established at the start by the National Committee that are distributed all over Egypt. Collaboration of the Ministry of Health with the nearby Faculty of Medicine provides the following services to this center: clinical evaluation and follow-up of the patients, lab facilities, radiology and endoscopic departments, and IT for data entry and collection. For standardization, we established applications written in the first visit by the patient, and then enrollment papers, then decision of treatment. This varies starting from the era of DAAs. At first it was whether a triple interferon included regimen or a dual non-interferon included regimen. And these dual varies start from SOF-REB, ribavirin, then SOFISIM, then SOF-DACLA, then SOF-Lidibisvir, Curivo, which is paritaprevir, ombitazvir, or Curivo and Riba. And also we specified in certain special conditions, everyone has a specific code list. Also, there is a follow-up paper for follow-up of the patients at week 4. A network for all patients' data for viral hepatitis treatment centers nationwide was established by the National Committee, and this network contains the detailed clinical data and contact information of patients during the enrollment and treatment, and after that the follow-up and outcome of treatment. This represent the peripheral centers, and all of them are collecting into the common national network. This flow chart shows the treatment procedure starting from the appointment given by the National Committee to the patient, then clinical evaluation by the physician, filling a checklist, the enrollment sheet, the data entry, collection of these data entry in the National Treatment Center, then a final decision, and the decision is sent online, and the patient started the treatment, followed by a follow sheet. For simplification, the appointment reservation was done online to a common website for the National Committee with the entry of simple data, just including the name and the ID number of the patients. The results of this simplification that in the first 3 days of registry, per day there were 100,000 patients registered on the line. After the end of the waiting list, the number now dropped to less than 1,000 per day. So less than 1%. The total number of patients who registered till March 2016 was 1.6 million persons. 36% whose age was from 50 to 60, then 26% from 40 to 50, 15% more than 60, and 13% from 30 to 40, and only 8% below 30. 63% of the patients were male, and regarding the sponsorship, 88% of these patients were sponsored by the government, and only 12% pay their treatment cash. Regarding this simplicity, there was a horrible waiting list by the end of 2015. More than 250,000 patients were waiting for the treatment. The barrier against establishing treatment of these patients was the cost and the limited, not only the cost of the DAAs, but the limited supply by the international company, also limited financial resources, the control of infection, and limited access to treatment. To overcome these barriers, the National Committee starts to increase the number of the units, decentralization and automation, developed Egyptian generics, and seek the help of the NGOs. The number of units increased starting from the end of 2015, from 53 now is more than 160 with the addition of the centers of the national insurance. Also by automation and decentralization, the duration starting from the first visit till the patient receives the treatment, it is reduced from 3 months now to less than 2 weeks. Then come the battle of DAAs. It is passed into 2 phases. The first phase is the negotiation, trying to reduce the price of the brands, and the next phase is the dependence on the generic drugs. This represents the success of the National Committee in reducing the price of the brands. For example, Sovaldi, its price was reduced to $300 per month, Semi-Prever $150 per month, DACLA $150 per month, Curivo $350, and Harmony $360. However, to treat this large number of Egypt, these low prices are not enough. So we start to seek for Egyptian generics. The first generic come in Egypt was the Sofosbuvir. We start by 6 generic. They reduce the price to $100, and then by the time this number of generic increased to 18, and the price becomes reduced to $50. Then comes the DACLA, at first also 2 generic, and the price was $10 per month. Then with the increase of the number of generics to 5, the price becomes reduced to $6.8. This is the old price of the dollars. No? Now it's $3 because it is 660 Egyptian pound is $3. So the cost of treatment for 3 months of the patients dropped from 10,500 per patient. It dropped to now 1,475, which is means saving or reduction by more than 85%. So the money saved over 6 months to treat the 600,000 patients in 2060. If we use the brand, this will cost $700 million, while using the generic, the price dropped to $100 million, saving $600 million. Regarding the limited financial resources, some NGOs helps in the sponsoring of the treatment. They sponsor the waiting list, and they help in treating 100,000 patients. These are examples of the NGOs which help the National Committee program. The real-life results of the National Treatment Program in Egypt. These are the protocols approved by the National Committee in Egypt. From 2007 till 2014, the treatment protocol was interferon plus ribavirin, and it was given only to F1 to F3 patients only. Starting from October 2014 till May 2015, the start of era of DAAs, we used 2 regimens. Sofosbuvir, interferon, ribavirin, only for F3 and F4 patients. Sofosbuvir plus ribavirin for 6 months in those who are interferon ineligible, only for F3 and F4. Starting from May 2015, we started to treat every patient with HCV, which means from F0 till F4. So we changed the Sofosbuvir ribavirin into Sofosbuvir Semi-Prever from F0 to F4, and starting from December 2015, we shifted to soft DACLA with or without ribavirin, also for F0 to F4. This shows the per protocol and the intent to treat results of SVR12 in the different regimen. For example, for the interferon soft ribavirin, the cure rate or the SVR12 was achieved in 92%. In cases F3, F4 patients. The ribavirin Sofosbuvir for 6 months for F3, F4 patients, those who are ineligible for interferon, the SVR achieved was 78%. The SOFISIM for all cases from F0 to F4, the SVR achieved was 83%. The soft DACLA with or without riba, for the 600,000 patients, the SVR achieved was 95%. So by 28th July 2060, there was no waiting list in all our units. And in Geneva, in 27th of October 2016, the WHO in a press conference announced the treatment of the first 1 million patients with HCV. 83% of them were treated in Egypt. Globally, high price of treatment remains a major barrier to access. However, this is not the case now in Egypt. The total number of treated patients in Egypt in March, few days ago, is 1,050,000 patients. The majority of them, 53%, are governmental supported, while 27% by the health insurance, only 80% private, and the police and army forces about 2%. This dropped the hepatitis C antibody percentage to 6%, while the PCR or the HCV RNA dropped to 4%. This represents a certificate of cure given to every patient who achieved SVR after SVR 12 after treatment. And the most important thing that this has been approved by the Conference of the Arab Minister of Health done in Egypt 3 weeks ago, so that they consider the PCR rather than the antibody as an indicator of HCV infection. So those who are PCR negative, even if they have antibody, they are allowed to travel and work in the Arab countries. What next? A national screening program is launched on September 2016 based on risk factor and based on age, and totally sponsored by the Egyptian government. But also there is another screening program helped by the International Bank, and it starts in the nation of in the governorate of High Egypt. Starts simultaneously. Aiming to decrease the incidence and eliminating the 150 to 200,000 new infections per year, with a comprehensive plan of action regarding the blood safety, avoidance of unneeded injection, disabled syringes, infection control measures, media awareness, and the mass treatment. And this plan of action for prevention, care, and the treatment of HCV. So, at the end, you can say that Egypt's success in reducing the cost of treatment has dramatically improved the access for treatment. Generic drugs reduce the cost of medication by more than 80%, whilst maintaining the high efficacy. Of the first million HCV treated patients worldwide, 83% were treated through the Egyptian National Treatment Program. The availability of affordable, effective generic drugs, increased diagnosis and the treatment, marked reduction in new cases through effective infection prevention control, political leadership commitment. This availability of all these has the potential, of course, to eliminate hepatitis C in Egypt before 2025. Thank you.
Thank you, Yehia, for this very interesting talk. We have still 5 minutes. Any questions? Yes?
Thank you, Dr. Yehia, for your wonderful lecture. I want to ask, when would be the certificate applied on the level, on practical level, so that people can really travel? You know, this is a very chronic problem that we've been facing for years with our youth that want to travel for work. So when they will accept it?
One is already present in the centers. It is already distributed since
The certificate
1
is
month.
present.
Yeah.
I mean, accepting the level of the PCR rather than the HCV antibody.
Yeah. Now as I told you, the conference of the Arab Minister of Health was 3 weeks ago, and he took a decision. It's already taken, but it has to be transferred to the Foreign Affairs Minister to give the order to the consulate or the embassies of these countries to change the test, instead of doing HCV antibody, to do PCR.
And then they used to reanalyze for the candidates when they reach the countries. So would this be applied to all the countries, or
Of course, this varies from country to the other, but the majority of the
Majority
NALs,
approved?
they accept.